as Bill mentioned, I think we are quickly circling this one and coming back with an exact proposal that will incorporate.
So you go back
this
to page 11 just to kind of get in. What we've been saying is that for the most part, all of these episodes are, relatively speaking, revenue neutral for most providers. We're trying to shift the curve to the right. And some of that is going to be your clinical judgment, your clinical comfort. Do you need to do the frequency of what you're doing? Do your pre-procedure consultants, are they efficient and effective? Perhaps you need a different clinical consultant in the beginning. I've done perioperative care, perioperative assessments. There's a great spectrum of care there. What is an appropriate way of dealing with the practice? We're trying to promote innovation. We're trying to promote safe and effective care and getting people to rethink what they're doing. There is no one-size-fits-all. It is very clear. And so we're trying to encourage some ways of stewardship that you feel comfortable doing.
Steve? One thing I would add is, remember, wherever we come down on the definition of the episode, where the targets are going to be set is going to include that definition. So we are not baking in any assumptions of efficiencies being created when we set these targets. So when we set the targets based on historical utilization, it is what it is. And so whatever inefficiencies exist in the system are actually going to be baked into the first targets that we put in place. So we're not, again, as I talked about before, we're not looking for best practices across the world and holding you accountable for that. What we're trying to do is to minimize the level of variation that exists within the system.
You start this project and you send feedback to the physicians about, okay, so here's where your costs lie. How does that break down to, for example, the example that she was given, right, where you were saying that maybe you have to think about referring to a different physician. Does the report capture that information so that there will be behavioral change? I mean, if I should put it that way.
No, that's the goal. The goal is to have people understand if there is, as was said earlier, there's practice variation. All right. I mean, technically, these data are being created for the episodes the same way for all of the providers. So some folks are here, and some folks are over here, and the question is, what's the difference? So and there are three major buckets. One is resource use, just style. One is patient mix. And the other is potential complications, bad outcomes. So, if it's practice style, and that's the issue, what is the difference between here and here? And, we're going to give people information they've never had before. So they can see in that whole picture. They know what their costs are, but they don't know how the environment they're interacting in. So it's actually been very illuminating to the OBGYNs, because they've learned some things, and we've learned some things talking to them. We found out, I'll just give you an example, that we have one doc in a part in the state who was an outlier, and it turned out that his local hospital, anytime a patient showed up in the ER during the pregnancy, was getting a non-stress test, regardless of what they were presenting with. If they were pregnant, they got a non-stress test. Well, that changed his cost profile dramatically, and perhaps that was something he might want to have a discussion about or deal with his local institution about. So there are things like that are floating around.
So hand right here.
In regards to the data, we've been following the episodes for quite a while, and you're doing the best to proactively work with them. And one thing we have found is there oftentimes is follow-up inquiries to really drill down, to act on them outside of the reports. And I think it would be helpful if there was a formal type data request, follow-on data request channel. I don't know if Matt, I might have him on speed dial, and I just, all right, I see that bucket. I need to know what's in that bucket, and my docs need to know what's in the bucket. And so I think as more and more as people begin to look at these and really digest them, almost always there have been follow-up questions, and I think if there's a formal channel to get that, I think it'll be helpful for everybody involved.
Yeah, and there is. I mean, I think each of the payers has a number to call if you have questions about that. One thing that to understand, too, is this is version 1.0, as others have referred to. These reports right now are static, but the goal is over time, to make these actionable so that you can click on stuff and drill down to claims line data and all that kind of thing. So these are going to get better. And it's just like with, when the health information exchange becomes a reality, then you won't have to put data in a portal. I mean, everybody will have access to the EMR and it will be uploadable on an automated basis. And so we're starting very conservatively, very rudimentary, but the plan is to take advantage of any and all automation that becomes available to us over time.
Hannah?
I have another comment, and I'm going to say, Dr. Golden, that I sort of respectfully but vehemently disagree with the comment that you made earlier, that there may be a significant percent of patients for whom a pre-procedure visit is not appropriate. And I do not believe that there is almost ever a time in which, before you perform a procedure like a colonoscopy, that a pre-procedure visit is inappropriate. I don't care how long you've been a patient. I know way more about colons than the average person, and it is still not just appropriate, but really necessary for me to go in and talk to that doctor. I mean, preps change. My medical history has changed. My mom started on Coumadin because she has a port now, but her GI would not have known that if they didn't have the pre-conversation, and she didn't know that was important. So in my opinion, I understand that the doctors may still get paid for that, but I believe that it is a very important part of the episode, because to me that indicates that it is a necessary part of this kind of procedure. And if we ignore that, then I think it is sort of sending that indication that it's okay to just sort of open colonoscopy schedule without having that conversation with the patient. And I personally do not believe that is appropriate, really almost ever. So that would be just my comment on that.
Let me ask one more. What's the name of this gentleman right here again?
Me?
Yes.
Jonathan Grano.
Okay. You had some comments before on what would be in the pre-procedure window, different visits, and so I wonder if you have a comment there, and then I'd invite our clinicians up here to also comment as well. So I think there's a microphone coming.
Payers actually do not pay for pre-procedure visits for screening colonoscopies. Medicare specifically does not cover a pre-procedure visit for a screening colonoscopy. Therefore, unless there's a severe comorbidity, we don't see patients prior to the procedure. Now, before we actually do the procedure, we do a short history and physical and address all the things you're talking about. You're still not paid for it, but you're definitely not paid for it if you see them a week or a month previously in the office. And you're incorrect. We're not paid for it, so there's an incentive to see patients the day of the procedure.
You had a comment before where, in terms of the fairness of what's included in the episode, your comment was, if there are pre-procedure visits, what if the patient showed up to another doctor who ordered all sorts of tests and things, but then showed up to you for the colonoscopy? Are you accountable for that cost? I'm hearing also discussion right now for actually, shouldn't we structure the episode such that we are including those pre-procedural visits? That's obviously a tension we have to sort out in the design, and that's what I'm inviting your comment on.
Okay.
Does that help?
Yeah, it helps quite a bit. So you're asking me to editorialize, which
I'm asking for your opinion, which will add to the conversation.
So I'm delighted to do. So. Before I get to the greater question, in comment to what Dr. Murphy had just said, absolutely there is not a requirement for a standard patient to have a pre-procedural pre-colonoscopy visit, and I understand why insurers like BCBS do not reimburse that directly, and I respectfully disagree on that count. With regards to adequacy of prep and anticoagulation, other pre-procedural issues, those in our case we cover by pre-screening with nurse calls and other educational activities, which obviously would decrease costs relative to shifting them to a full provider. However, I think that a lot of the push-pull in this room, as I can feel it, is that my colleagues who are in practice, some in smaller towns, may have a very different way of intake for their procedures than we do here at UAMS. If I were a solo or small group practitioner in, a middle-sized town of Russellville or something like that, I might very well establish my practice in a way where I do the intake initially and make sure that I'm familiar with all the issues regarding the patient. Here at UAMS, where we're asked to really have the care of the entire state funneled to us, including the greatest percentage of currently non-insured patients, the greatest percentage of patients covered by Medicaid and other situations like that, we would never have the resources to simply have all our patients seen initially in GI clinic prior to being seen. And so the model that we run and the model that almost every large academic medical center in the nation runs is to use an open endoscopy unit. For some people, that would be a very scary proposition. I wouldn't want to ask anybody to do that unless they had the combined resources to run such a unit. You need the kind of throughput that we have. We've got 4 surgeons, five surgeons and 7 gastroenterologists, all of whom are doing procedures regularly. Very few places are going to have that kind of throughput, and thus wouldn't have the nursing support, the other support. So I can understand if I were on the other side of that wall, I could understand why some of these things would scare the heck out of me in terms of pre-screening.
I have one more just question on this, and I want to move us on because there's some other material we do need to cover. My last question on this is for my clinician colleagues here and others in the room here. If you take a diagnostic colonoscopy as an example, if you have a certain patient that's, say, on Coumadin, and let's say there was no pre-visit, so the prep period, basically what I'm asking is there any impact on the outcomes of that? Is there a incompletion rate? You're going to have a revision immediately after. Are there other things that will happen that basically would be captured in that overall scope of the episode? I ask this because if there is that, there is an incentive where, if it makes sense for a given patient to have that patient in to actually manage the overall outcomes and cost of that episode, physicians or PAPs would be incented under this model to do that. It's a question for my clinician colleagues if that is indeed the case.
There's certainly an increased complication rates, people on Plavix and Coumadin and blood thinners. So the increased cost is going to be associated with increased bleeding rates or complication rates post-procedure.
Yeah, I think it's more complicated.
It's more complicated, and there's a reason we're excluding respiratory disease. I mean, there would be a reason to exclude significant cardiac disease as far as the cost model, because those patients have an increased risk and more complications, and that's one of the comorbidities we need to look at.
Right.
Yes. So with regards to oral anticoagulation, which for the most essentially Coumadin, there are a variety of reasons people are on Coumadin. If the reason they're on Coumadin is atrial fibrillation, they can be safely stopped with absolutely no increased risk prior to the procedure and restarted for the vast majority of them immediately post-procedure. There's no evidence that there's increased risk of CVA, and Dole, I'm sure, is shaking his head. In support of that, on the other hand, a patient that has an active thrombotic disease, has a prothrombotic condition, and has to be maintained at a high INR, some of those patients are at such a high risk that they're best served coming in and actually going on heparin. But that's a tiny minority of patients that are on Coumadin, and then there are the small group in between. With regards to platelet inhibitors, there's pretty good evidence that at least removal of small polyps, that there's no increased complication rates that at least that result in hospitalization or increased expenditures. On the other hand, Plavix and now the other P2Y12 inhibitor type drugs can be an absolute disaster, and not recognizing the difference between those will result in folly.